Welcome back to Plastic Surgery Untold. This is a wonderful podcast. We are here in Miami at the ASAPS meeting. We're going to be talking about facelifts today. I'm going to have everybody really quickly introduce themselves. I've known Paul for a long time. Why don't you tell who you are, where you practice, and, why don't you go for it?
Great. It's great to be here. My name's Paul Afrooz. I'm a plastic surgeon here in Miami, Florida. Conveniently, this year the meeting is in Miami. My focus in my practice is facial rejuvenation surgery, rhinoplasty, and revision rhinoplasty.
Wonderful. And you didn't break a sweat walking here, so you didn't drive here, right?
That's right.
Okay.
Miami traffic is really something you got to reckon with. So despite living only about 10 miles away, it's about a 40-minute drive.
Wow. All right. Well, your commute would have been a lot longer. Mark, why don't you tell people, full name and where you practice?
I'm Mark Albert. I practice in New York City. I'm in private practice. I also have a position through Northwell Health where I'm director of a fellowship where we teach aesthetic surgery to 2 people per year. Just like Paul, my practice is very similar. I do a lot of rhinoplasty, a lot of revision rhinoplasty, and facelift and neck lift as well. So it's a pleasure to be here. Thanks for having me.
Yeah. Oh, yeah. You're welcome. And then Sean Arredondo. Oh, I shouldn't have given your last name because you're supposed to be doing that. But I know you quite well, but not everybody does. Why don't you introduce yourself?
Yep. So I'm a fairly recent grad from Ohio State, where I did my 3-year plastic surgery fellowship.
Go Buckeyes.
That's right. Go Bucks. OH.
IO.
And most of my practice right now consists of body surgery, and then I've done a fair amount of stuff under local in our procedure room where you're involving more face and extremities. And I'm really trying now to branch more into some of the facial aesthetics. So I'm really excited to be here to learn from some of the secrets from the masters over here.
Yeah, and I think that'd be great because I'm going to try to prompt some discussion, but I think you can too, given your sort of perspective on things. Okay, well, we have a limited period of time, so we're going to talk about facelifts. And one of the sort of the hot topics that is talked about a lot at the meeting, and I know that patients are asking about mostly because of the exposure on social media, is the deep plane. So how about briefly, whether or not you have a procedure that involves it, we'll get to that in a second. You want to just very briefly tell patients, savvy patients who already know a little bit, what are we talking about when people are talking about the deep plane?
So the deep plane facelift with respect to plastic surgeons refers to a very, very specific operation that was invented, I think, in the early 80s. So when it comes to plastic surgeons referencing the deep plane facelift, when we think about that, we're thinking about a very, very specific operation. I think that phrase, deep plane, has evolved because of social media and exposure to certain very talented surgeons in particular. It has become to mean a much more broad subsmaster surgery. So I think nowadays, from a patient perspective, any surgery that involves elevating the SMAS and being under the SMAS is now kind of lumped into this category of a deep plane facelift. So we're trying to have this discussion from the perspective of a patient. So I'd like to focus more on that. And I think that any subsmaster surgery nowadays from a patient perspective is referred to as a deep plane. Would you guys all agree with that?
I agree. And what I'm gonna throw something at Mark here, just for a minute. Describe what the SMAS is,
right.
and then sort of address what Paul said.
Right. So when we think of the face, the most outer layer is the skin. Just beneath that is what we call the subcutaneous layer, where it's a thin layer of fat. Underneath that is our SMAS layer. And it's a layer of basically fibrous tissue that's firm and can be manipulated in order to create lift and do other things with the face. So that's what we're talking about. A deep plane is going deep to that layer of the face. I think that's a pretty simplistic way of thinking of it.
Yeah. And then I think, and what Paul was hinting at is really important, and that is that, because I saw this at a meeting, is that the way that it was described initially, it being the deep plane facelift, was a composite of, meaning a sort of a union that's a natural occurring adherence between the SMAS, as you had described, and the overlying skin. And in that initial description of the deep plane procedure, very little skin was elevated, moved around. They went immediately to that deep plane and then lifted everything, the skin and the SMAS together. Now, I don't know what everybody does, so I'm gonna ask Mark, and then we'll work to Paul, and then we'll ask Sean. What do you do? And I should preface this by saying that there are a lot of really wonderful facelift procedures. It's not to position one as better than the other, but with respect to that, what do you do?
Right. I think for deep plane, the idea is to differentiate between whether it's a composite, like you were alluding to, or if it's more of like a bilamellar, where you're elevating the skin separate from the SMAS versus doing it all together. Mm-hmm. So my preference actually is to separate the SMAS and the skin, so you can pull in different vectors.
So you move them in different vectors,
mm-hmm.
right?
Yeah.
Paul, I know what you do, but why don't you tell the audience?
Yeah. So what I do has really become more tailored to each individual patient.
I guess I don't know what you do.
Yeah. So I started out doing. I consider myself a disciple of the bilamellar high SMAS
mm-hmm.
procedure, where the skin and the SMAS are elevated separately, and they are transposed, meaning they are, for lack of a better word for this audience, they are pulled different lengths and different directions. There are advantages and disadvantages to that, but I have I have carried out the present day definition of the extended deep plane facelift. I think there are some advantages there too. So my answer is, there's so much variability in facelifts. There's so many marketing terms being thrown around, like vertical facelift, vertical this and vertical that. And I think that is a very talented surgeon's marketing strategy, but vectors change from patient to patient. So we can't just uniformly adopt that vertical is the best thing for every patient. Yeah. It very specifically has to be tailored to each individual patient, and there's so much decision making that goes into that preoperative plan.
Yeah, Sean and I have talked about this some, but and where we ended up with this is that there aren't necessarily procedures. There's patients, right?
Mm-hmm. Exactly.
We have patients in front of us. And then, we all know the variations that each patient is going to benefit from, and we create a procedure for that patient. And so now, when a patient asks, do you do a deep plane facelift or is it vertical? You know what my answer is? I want to do your facelift.
Mm-hmm.
Right.
Yeah, I want to do your facelift. Let's talk about what I think is going to work.
I love that.
Well,
answer.
it's so important, I think, because every patient's face is different. The stresses, the changes that have aged them are different, but even more so, we haven't talked about this at all, but we have probably 1,000 people that have come through the office this month alone for our skinny shot. So they've lost, some of these people have lost 30, 40 pounds. Some people have lost 70 pounds. And the changes that we see in their face are so different. So how do you, in your minds, take that patient who's maybe in their 30s or early 40s and has lost a significant amount of weight, has sagging skin, as opposed to, just the age that the 50 or 60-year-old? How do you treat those patients differently?
Yeah, for me, it comes down to whether you want to incorporate fat grafting to it.
Mm-hmm.
I assume that you're talking about the Ozempics.
Oh, yeah, Ozempic face, all that stuff.
Right. And so we know that we lose fatty tissue with that. And so adding fat back into the equation really helps with those patients.
Mm-hmm.
One thing worth mentioning, I'd be curious your experience with, are you having people stop it ahead of time? That might be an interesting topic for the audience to hear a little bit about. And what are the risks of being on it during surgery?
Yeah, I've probably seen the highest volume of those patients in our office. I'm new in practice, and if my schedule's not full, I say put a patient in there. I'm not going to say no. And because of the delayed gastric emptying, just that slowing of the emptying of the stomach made me a little nervous after talking with our anesthesia colleagues. Okay, are we going to have higher aspiration risk? Do they need to be NPO sooner than just midnight before the surgery? Should they eat dinner? Should they not eat dinner? A lot of what I do is body contouring, so a little bit different than this, but you've got, miles of incisions. So are they able to eat enough protein to heal? And so, I'm a very strong believer of the prehab before surgery. And so, we stopped them 2 to 4 weeks before surgery, just depending on what the procedure is. For most of the face stuff, I think we've been doing about 2 weeks.
Yeah. Yeah, and that these safety questions are really important. I'm glad you asked. I'm glad you had a good answer. I want to step back to something that Mark said because, and it relates to. I'm so glad you introduced the idea of discussing the Ozempic patients. So, how would you address this if a patient came in and they were like, I want to have a facelift. I lost all this weight. And you're like, okay, well, an important component of this is going to be to inject some fat into your face. And they're like, but wait a minute. I just spent a lot of time losing weight. So help the patient understand where you're adding fat and the value of it. And then, Paul, I definitely want to hear your input on this as well.
Right. My short answer is oftentimes centrally, especially, I find that even after a facelift, patients can be deficient if they are deficient in that area. And what I mean by centrally is the cheek tissue right next to the nose, basically, underneath the eye, next to the nose. So that's a nice place to frequently add fat. And also the nasolabial fold sometimes. That's another area that's nice to add fat.
Are you adding any fat to the superior sulcus on your patients?
No,
sometimes?
not routinely.
I'm going to, quick little technical point. So when you do fat to the nasolabial fold, are you injecting it subcutaneous or do you put some adjacent to the bone or both?
Both.
Okay. So we've got his answer. Paul, do you do the same?
Pretty similar. I want to comment on your last question. So I think a lot of the nasolabial fold exacerbation begins with piriform atrophy, and
I was hoping we were going to get into this. Thank you.
It sounds like you all are on the same page. So I think there's a lot of power in building up the piriform, being on bone, building up that piriform, which is, in my opinion, the source of that nasolabial fold. So trying to advance that maxilla. It is very powerful for dealing with a prominent nasolabial fold. And of course, I will fill in the groove of the fold itself, but I think that adding to the piriform and the maxilla is a far more powerful procedure.
So this was an amazing conversation. What we just talked about right here. And we could write a whole chapter on that particular issue. We have really intelligent, savvy patients. But I think we got, and I wanted it to be technical, but I want someone to volunteer to just explain, and it could be Paul, Mark, or Sean, what he was talking about, because it's the relationship of the bony skeleton, the volume of it, what happens, and then the soft tissues that we see from the outside. So who wants to grab
I'll
that
let
one?
you guys, please.
Yeah. Okay,
So,
Paul.
yeah,
back at you.
So very similar to the marionette lines. I think this process is ubiquitous in several areas within the face and the body. I think there's an initial point of volume reduction that the downstream effects of which lead to a deep crease. And for the nasolabial fold, I believe it's recession of the piriform. So for those of you listening, the piriform is really that area right where the nostril meets the cheek. And over time, with age, we tend to lose a little bit of bone. And recession there causes a deepening, and that deepening just sort of...
It's like a black hole.
Exactly. It facilitates is probably the wrong word, but it creates... it initiates a cascade of deepening, and the fold, I think, gets worse over time.
Yeah. So if we think about the nose as a whole, the bone around it is the piriform aperture, and so that lower part of that triangle, the base of that triangle, if it's sitting on a table, that's the bone that's creating that is the area that we're talking about. And when there is loss of that bone over time, it pulls in part of the junction of sort of the lip, cheek, and the nose, and that's what exacerbates the nasolabial fold. The nasolabial fold, or actually it's the nasolabial crease, to get technical, that it's exacerbating. The fold has to do with descent of the soft tissue in conjunction with that. So this is a great way to get back to sort of our discussion of the deep plane and the management of the skin. What do you guys think is the best way to elevate that malar fat pad? So malar fat pad being the sort of central fleshy tissue of the cheek, so as to get it up away from that crease, so that we, in conjunction with our fat grafting, the piriform aperture, how do we do, not the aperture, but the piriform bone? How do we help do two processes to have a less deep crease and a less heavy fold there?
Right. I mean, I think a lot of it comes down to, I mean, as we've already covered, this term deep plane is complex, and there are a lot of different ways to approach it. I think almost the more anterior you go, the closer you are to the fold, as far as where you make that entry deep to the SMAS, has a lot to do with how well you can pull that.
Yeah,
and with that said, even if there are people who don't do deep plane facelifts, they can still achieve great results. I mean, we were talking earlier today about how you can do plications in different parts of the face, and if you focus a plication right down near the nasolabial crease, nasolabial fold, you can achieve a great result with that.
I think that's a really important point, and I will just very briefly talk about what I did. I spent a lot of time in residency and fellowship learning about subsmaster dissection, and so when the first third of my practice, I did mostly that. And then actually I migrated to plication. And then I've kind of come back now in the last third of my practice to doing a subsmaster dissection. And I've been very happy with all of them. I want to go to meetings and see them presented. I see wonderful examples of both. So how about in residency, when you had a lot of wonderful mentors, you've talked about them. Tell me what you saw there.
So what I saw a lot of was plication in our private practice office. They were a little bit older, so they were more comfortable doing plication stitches, almost like a max type lift to really get that movement. And they would add sometimes that third stitch up there. But we had someone come from Southwestern who trained under Spartan, and he introduced the high SMAS. And when I saw that, I was just blown away with how well that repositioned that fat. And it was, to me, that's my favorite technique to really restore that volume there. I think it's just the exact right vector, the exact right position to fill that area.
You mentioned anesthesia earlier. What do you prefer as far as anesthesia for these procedures?
Oh, for these?
In your practice?
I put people to sleep.
Okay, so I put, well, I don't put them to sleep, but I work with a team who puts patients to sleep. I'll be honest with you, I'd love to do a TIVA without, without the patient intubated. And I think that, we're going to have some evolutions in our particular practice where we're going to be able to have that be a reality. But I think both are wonderful, really. In my experience, it's been about the provider, though, because there are some CRNAs that we work with. They're intubating the patient, but they have them extubated and literally out of the surgery center, totally safe, totally alert, within 30, 45 minutes. So it's not, Paul?
So we do a mix of everything. It's we let patients contribute to that discussion and what their goals and desires are. It's very easy for everyone to do a general anesthetic. It's easy on the CRNAs or the anesthesia provider. But there are, waking up can be a little bit slower depending on whether the provider is using vapor or purely TIVA propofol. My preference is to do as light of an anesthetic as possible to achieve the objectives of the operation.
Mark, you asked that question. I'll bet you got some info to drop on us here.
My preference is to do one of the two ends of the spectrum. The more, we'll say, aggressive end is general anesthesia, putting an LMA or a tube down to secure that airway, or doing it totally awake under local anesthesia, where we give oral medications. We call into the pharmacy. They bring them with them, take them 15 minutes before. And we're talking, patients usually take a little nap, and we have laughing gas as a supplement.
So to give us a little bit more detail about that, because I think patients will find that interesting. And I think that's going to be a horizon that we're going to be moving towards for patients who are interested in that, because not every patient wants to be awake.
Exactly. You're exactly right. Right. So there are specific medications that many people often take on a regular basis at home anyway. And it's basically a combination of Valium, Benadryl, and Percocet. That's what I prefer. And yeah, there's a numbing process where they feel a little poke and burn behind the ear, and then you'll feel the cannula underneath the skin shooting out the numbing medicine, and then they don't feel anything.
And you mentioned laughing gas, so I imagine you're using Pronox or equivalent for perhaps the injections and other times.
Exactly, and that's it, just that first 10 minutes.
Okay.
So we're running out of time a little bit, and I know you guys have other busy things to do and check out the meeting, but just before we wrap up, are there any tips or tricks or sort of pearls for the recovery of these patients after going on the procedure that you want to leave us with?
Yeah, I mean, I think for me, what I really emphasize for people is just be prepared to really take it easy after the procedure, because blood pressure control after a facelift or neck lift is so critical. And also making sure that your blood pressure is well controlled. If you have hypertension, make sure you're well controlled before the procedure. So just be well prepared, have family members in place, get all your grocery shopping done ahead of time, and just prepare to chill.
To that, are you using clonidine at all with your
Yeah, I do use clonidine.
Yeah. Oh, yeah. I kind of was hoping we would talk about that. Maybe we can do it a little bit in our rhinoplasty discussion.
Great.
Yeah. What's coming up next? Paul?
Great. I would echo everything Mark said. I completely agree. I think one of the main issues that I want to emphasize to patients is that you're pretty much going to feel fine within 24 hours after the surgery, but I've got to put the brakes on you. So I need you to take it easy for 1 to 2 weeks. Most often it's 2 weeks. I just need you to take it easy. I need you to have help around the house. I don't want you doing anything strenuous during that time. So those are the main factors, and I think Mark very nicely touched on those.
Yeah, you want to protect that investment. You've just taken all this time, all this effort to craft that beautiful face and sculpt everything, and that recovery is so important for patients.
Exactly.
Well, we'll say goodbye real quick. This is Sean Arredondo, Adam Weinfeld from Austin, Texas. We've got Mark Albert from New York City and Paul Afrooz from Miami. We're in his hometown right now.
Thanks for joining us, guys.
Thanks for having us.
Yeah.